Burn Wound Care, written by Mary Mondozzi, presented by Mary Mondozzi from Akron Children's Hospital Burn Center. Objectives for this module include identify factors for initial burn wound care, list special considerations for debridement, and discuss factors for the maintenance of burn wound care. When we look at burn wound care, there's many goals that we want to attempt with this. We want to clean or debride necrotic tissue or dead tissue, remove any drainage, which is called exudate, or that loose dead skin, remove old dressings, ointments, or creams, minimize further destruction of healthy tissue, promote burn wound re-epithelialization, which is healing, promote patient comfort, and reassess the burn wound itself. When we look at the purpose of wound care, it's one of the many components of burn care, and when the skin barrier is disrupted, it causes direct problems for the entire body. When we put on a dressing or a bandage, it has three principal functions: for protection, to help with metabolic needs, and for comfort. When we look at protection, the physical barrier is lost, including antiseptic properties. Environmental flora grows rapidly on the burn wound surface. With metabolic needs, burn wound dressings help reduce evaporative heat loss. They impede water vapor loss. They minimize cold stress and shivering. When a patient shivers, it generates heat, and shivering does use energy. It minimizes also the nutritional demand of the patient with major burns when we look at putting on a wound dressing. And the last principal function is for comfort. When we look at burn wounds, they're extremely sensitive to the air current. Air current causes pain. Deeper burn wounds become more tender with time since those nerve endings are starting to regenerate. The wound dressing can absorb and contain secretions, and it can help provide any type of splinting to maintain a position of function. Now, when we look at wound care, if the patient's transferred out within 24 hours, what you want to do is cover the patient with a clean, dry sheet, protect them from heat loss. Make sure you use some type of warm blankets to maintain the patient temperature. You would never want to use wet dressings or wet sheets, because what's going to happen is that patient is going to pick up that wetness and it's going to drop their core body temperature. So we want to make sure we keep our patient warm and dry. Supplies for initial cleaning include personal protective equipment, a mild bland soap, tap water, washcloths, towels, a tub or a basin to put that water in, scissors, tweezers or pickups, razors, and clean linen for the bed. Cleaning of the burn wound is a clean procedure. It does not have to be sterile. Universal precautions should be maintained throughout this procedure. For patients with large burns, and that would be 10 to 15% for a pediatric patient, 20 to 25% for adults, the following should be worn: clean gloves, a gown, mask, and a face shield or goggles. Initially, when we clean the patient, you want to make sure that environment is nice and warm. You want to wash the wounds with warm tap water. Use a mild soap, especially if there's excessive debris or if you have soot on the patient. Use clean washcloths, and when you use those washcloths, you're going to use a different one for each part of the body. You will also use scissors and forceps to debride blisters on patients being admitted and for any loose hanging pieces of tissue. Now, when we talk about blisters, management of blisters are very controversial. There's limited evidence for consensus on management for these. If we have a patient that's going home, for small blisters, maybe the size of a pea or so, you're going to leave those blisters intact, because they act like a biological Band-Aid. So what you would do is put your ointment and your dressing on top of that. For large blisters, which would be equivalent to a quarter or 50-cent piece, you would cut into the blister and allow the fluid to drain. You would leave that skin intact because, again, it acts like a biological Band-Aid for them. Blisters over high movement areas are going to break anyways, so you might as well just break those, and you want to apply your ointment and then your dressing. For patients that are going to be admitted, they're in more of a controlled environment, so you want to excise and break all the blisters. You're going to use your forceps and scissors and remove or debride that sloughing skin or skin that's hanging. It is very important to make sure you clean the burn wound before applying any ointments or dressings to that area. Hair should be shaved from around the burned areas only. When we look at shaving the hair, it allows for a more accurate assessment of percentage of the total body surface area that's involved. Also, when you shave hair, it cleanses the area of bacteria. Bacteria may adhere to the hair and those hair follicles, and it can cause complications such as folliculitis, which is an infection of the hair follicle. When shaving, it should extend 2 to 5 centimeters around the burn wound area edges. And you would never want to shave eyebrows. Those will not grow back, so we want to take care around that facial area. If you have embedded material, lots of people question, well, how do I get that embedded material out of there? You want to try to clean it gently with soap and water. Some of those larger particles, you can use tweezers or pickups to get it out. And sometimes it's not always possible to remove all this material. So what you want to try to do is, after removing as much as possible, or as much as the patient can tolerate, your burn dressing will be applied, and it may lift off more over the next few days. Dressing changes and routine cleaning should be done once a day. We do have to make sure that the environment is warm. Also, tepid or warm tap water should be used. The patient can be changed in the bed, a treatment room, or even taken to a tub if it's available. If the patient's changed in bed or in the treatment room, we use a clean basin to put the water in. When they're taken to the tub, one of the things we have to make sure is that they're not soaked in the tub. It's not common practice for immersion therapy, which means soaking that patient in that water. What you want to do is, of course, you would remove their dressings, and then you would have them over the tub where you can spray or rinse off those wounds and clean them. And then once those are cleaned, you could give them their bath and then apply their dressings when that's done. For our dressing changes, make sure you use your personal protective equipment. You're going to get off those old dressings. Now, of course, you're going to have clean gloves to remove this. Use scissors to cut out the outside coverings or securement that's holding those dressings. One of the problems can be that some of the dressings can stick to the burn wound. If that occurs, you want to soak it off with a little bit of water, and that's going to help reduce the trauma to the area. As you can see from the picture in the slide, many times dressings can have drainage or exudate on them. So don't be concerned if it looks this color. Now, if it's a dark yellow or a green color, that could mean that there's infection that's occurring. You want to make sure you change your gloves before beginning to wash the burn wounds. So when we talk about washing the burn wounds, you're going to use a clean washcloth, wash in a firm circular motion, and you're going to make sure you get off any kind of medication or drainage. You may have to trim some more sloughing skin. You're going to use a mild bland soap, such as Ivory or baby shampoo. Baby shampoo is really good to use when we talk about soot. If you do use some other type of mild soap, just make sure it doesn't have any perfumes or added fragrance. Antimicrobial soaps and products such as betadine or iodine are too harsh and prevent burn wound healing or that reepithelialization. Now, sometimes when you're cleaning, the burn may bleed a little bit, and that could be due to the fragility of the skin or those skin buds that are starting to grow back. What you do want to do is apply firm pressure with a washcloth to that area. When we apply our dressings, There are many types of burn wound products that are available. When we look at burn wound dressings that are appropriate, they're used for two reasons. According to the size and depth of the wound, according to that superficial, partial thickness, or full thickness type of wound, and so that the dressing doesn't adhere to the burn wound as the skin heals. There are many, many products that are available, but the products most common to institution other than burn centers are Alogel, bacitracin, polysporin or neosporin, Silvadene, which is also called silver sulfadiazide or SSD, and then there's coverings such as dry sterile dressing, 4x4s, 4x8s, and Kerlix. When we look at the types of dressing application, there's two main types, open method and occlusive or closed method. And according to your body part, we're going to decide which one we're going to use. When we talk about open method, it's most often used for faces and ears. And what happens is you take that topical agent or ointment and apply it directly to the burn surface. The burn wound's then left open and no outer coverings applied to that area. Closed method or occlusive method is used on all other body parts. You're going to take that topical agent and apply it directly to the gauze, and then the gauze is placed over that burn. When you do that, you're going to cover it with some layers of bulky gauze, and then you're going to secure it with some type of flexor net or some type of netting. There are many techniques of securing dressings, and it depends on your body part, the amount of mobility that you need for that body part, and the age of the patient. If you're using Kerlix to wrap an extremity like an arm or a leg, within the first 24 hours after the burn injury, make sure that it's applied very loosely. And what you want to do is assess for swelling or circulatory compromise, since that Kerlix doesn't give any at all. And it can cause what we call a tourniquet effect. And what that'll do, that can press down on the area and cause decreased blood flow to your extremity. Do not use ACE wraps to secure your dressings. When looking at the different types of burn injuries, with superficial burns, mainly they're treated with aloe vera gel. What you want to do is first rinse off the area with cool water. You can pat that area dry, and then you're going to apply the gel. You would do that liberally at least 3 times a day. When you're applying those a second time, make sure to wash off the area with a clean washcloth before reapplying that gel. You do not put any covering on top of that gel. After a couple days, usually 2 to 3 days after that injury, a good moisturizing lotion without any perfumes or dyes is needed. With partial thickness burns, we're going to use bacitracin, polysporin, or neosporin. Just make sure you don't use Silvadene. With that Silvadene, what happens is that the eschar builds up on it more. It's called a pseudo-eschar. For faces and ears again, what we're going to do is we're going to apply a thin layer to the area, and we're going to repeat it at least 2 or 3 times a day. You're going to squirt the ointment from the tube to a sterile gloved hand and then apply it to the wound. And you want to make sure that if you apply that to the wound, that you do not get the tube contaminated. If you have a jar of this bacitracin or so, you can take a sterile gloved hand and dip it into the jar and then apply it on the wound. You just remember that you do not place your hand back into the jar once it touches that burn wound. And again, like we said, when you're reapplying these ointments, you're going to make sure you wash them off with a clean washcloth before reapplying them. With partial thickness burns and any other body parts other than the face and ears, the preferred method is to apply the topical agent or ointment to the gauze first. So what you're going to do is you're going to prepare the dressings in a sterile fashion. You would want to take a sterile gloved hand to apply a thin layer to a non-adherent dressing or non-cotton gauze. When we do the application of the dressing to the patient, it begins as sterile, but then it progresses to a clean process. When you have your dressings, you're going to place them on any open burn areas. And just be careful not to overlap too much on unburned skin, since this can lead to some type of irritation. Now, if this is within the first 24 hours, you do want to make sure that you have enough dressing on that patient, because as they swell, that dressing can not be in the areas that it's needed, and so you may need to repair that dressing. You want to make sure you wrap fingers and toes separately and then secure it with some type of gauze or some similar device. There is an alternate application method, and what that is applying the topical agent or ointment to the wound itself. You're going to use a sterile gloved hand or a tongue blade to apply the ointment directly to the burn wound. Remember not to put your hand or tongue blade back into the container after it touches the patient. So it's kind of like you're putting icing on a cake. That's how thick you want to do it. After you apply that ointment, then you're going to cover it with gauze. Make sure again to wrap fingers and toes separately and secure the gauze. With full thickness burns, this is where we use our Silvadene. Silvadene is not to be used on patient with sulfur allergies. In that case, we're going to use those products for partial thickness burns. Open methods for your ears again, and occlusive methods as described previously for all other body parts. One of the biggest points when we talk about wound care is that it's very painful. You do need to medicate the patient. Depending on the size and depth of injury, you can give IV medication or oral narcotic agents. IV route is preferred with those large burns due to the massive swelling in the tissues. If you would give them something IM, it's really not going to reach that patient. You can use anti-anxiety medications because those are very useful in conjunction with the narcotics. Just remember that anti-anxiety medications do nothing for the pain. When medicating, you want to pre-medicate the patient before the dressings are removed. And you're going to look at that medication and time it with its peak effect of the drug and that procedure. You can also medicate the patient at intervals during that cleaning process because it is very painful. Common IV medications include, but really are not limited to, morphine, fentanyl, and Versed. If the patient's going to be treated and released, you want to make sure that they have a prescription for pain medication. When this pain medication prescription is written, you want to make sure they have an adequate supply until their follow-up appointment. You may need to write for additional medication because maybe that person is expected to change their dressings at home. Remember, with dressing changes, they may need to take that medication before that dressing change. You want to make sure we educate the patient and or family. They need to know what to do to care for that burn. What are they going to expect if there's signs or symptoms of infection, healing, pain, nutrition? They need a lot of calories and proteins for that burn wound to heal up. If they have itching, what should they do? And then if they're responsible for dressing changes. You may be able to give supplies for dressing changes. If not, you would let that patient know where they need or can obtain these items. And homegoing instruction sheets are very important because it's better written down than remembered. Some people sit there and agree with everything, but they forget it once they leave the unit. In summary, wound care is one of the many components of burn care. The main purpose is to clean the burn wound, remove necrotic tissue, minimize further destruction of viable tissue, promote wound reepithelialization, promote patient comfort. According to the size and depth of the injury, blister treatment, the type of topical agent, and the dressings can vary.